My next guest is Dr. Robert Gabbay, Chief Scientific and Medical Officer of the American Diabetes Association. The association provides clinical practice recommendations or standards of care for diabetes. He's also an associate professor at Harvard Medical School and has focused his research on improving and enhancing the lives of people living with diabetes. Big welcome to Dr. Gabbay. Doctor, you heard perhaps some of my conversations with the congressman. Look, I've talked with Michael Burgess before, and he really does care about these issues, and you can kind of feel that in the conversation. And particularly the one I opened with is just say, hey, what can we really do to be game changers? You're at the sort of mothership of patient focus connected to the field and profession. And I know you've recently had some recent conferences on looking at everything from standards of care to metrics and other dimensions, but if we want to sort of come together 5-10 years down the road and have seen some levers moved, which ones are you advocating we shift?
Well, thanks, Steve. I think there are a number of important issues, and some of those you heard from Dr. Burgess or Congressman Burgess, who's been a great advocate, as has the Diabetes Caucus more broadly for a number of agenda issues. One of the things we realize is that there's been a great deal of innovation in the world of diabetes, but it's not reaching all people, and that's where we need to do better. So improving access to the right treatments is critically important. And the American Diabetes Association last year launched an effort, Health Equity Now, with the Patient Bill of Rights, that essentially places the importance of access to the right technology to manage one's diabetes, the right medications, to the right treatments, as at the forefront of where we need to do better. So that's certainly one big area. Another big area is around access to healthy food. We know that 23% of people with diabetes live in food deserts or food swamps. And so you can educate all you want about what's healthy, but if that's not accessible or affordable, people don't have access, and sadly, their outcomes are significantly worse.
I think that is such an important message, and I hope people are listening. But let me ask you this, and we didn't coordinate this. I just want to know, if you were to go to Baltimore, to a zip code in Baltimore where there is a life expectancy difference between certain areas, nice areas of Baltimore, and where people are rich and wealthy and have resources, another part is a 20-year difference. And so when you talk about food deserts and you talk about just different socioeconomic environments, different racial environments, I just want to know, I want to hear someday somebody in this field say, we've gone into this zip code and we have taken these steps and measures and we've changed the direction for a lot of folks, and we've found some best and promising practices to build on, as opposed to continually to talk about the gap. I'm editorializing here, but has there been any play that has done that has begun to look at best and promising practices in the trouble spots?
It's a really important point, Steve. So two things that we're focused on at the American Diabetes Association is one, this year, targeting our research funding around addressing health disparities. And when I say addressing health disparities, it's exactly what you're talking about, not just measuring it and saying that there is a gap, because we know that already, but what are interventions that can be done to mitigate those? So that's one big area. The other is that we, through our Health Equity Now platform, we've partnered with large interests in various communities to do scalable pilots that could really demonstrate how we could do better, and whether that's in Columbus, Ohio, and thinking about how we can improve access to continuous glucose monitors for people of color, to with Abbott, to working with Walmart in the Chicago area to significantly improve access to both healthy foods and the right treatments. We're building this network of understanding of what works so that we can scale it.
Another big question I have is, while type 1 and type 2 diabetes are driven by such different factors, oftentimes the prescription or the pathway to deal with those challenges are similar. But I know you've been working a lot on personalized medicine and personalized approaches, which I find to be very important in this, because everyone sits in a slightly different world. with slightly different pressures. And I often feel like, with someone whose family has suffered a lot with obesity challenges through multiple generations, and people say, well, just pick yourself up and get control of this. It's not always that easy. And so part of the question is, in the personalized medicine field, what can be done to begin to get people where they're at, as opposed to one size fits all sort of prescriptions that miss a lot of people?
We're really on the cusp of a new level of understanding of how to really exercise precision medicine to ensure that the right person gets the right treatment at the right time every time. And it's having, we are now in a technological level where we can have that kind of data that is necessary to be able to identify the specifics of an individual and what might be effective for them, whether that's the way we message, whether that's using digital health tools, whether that is ultimately understanding which treatments are going to be most effective for which individuals. We're now at a point where we can really start entertaining that in a really productive way. So this is very exciting.
We have a question from our audience named Larry Holman, and he asks, how can diabetes be prevented? Wouldn't it be more economical to prevent the disease than to manage it? I mean, it's an honest question from the audience. What are your thoughts? This is the kind of question the public needs responses to.
Absolutely, and that goes to what Congressman Burgess was talking about. So, there is the diabetes prevention program. So the good news here is, in terms of preventing type 2 diabetes, we have the science, we have the knowledge of what works. There was a study funded almost 2 decades ago, the diabetes prevention program, that demonstrated that you could reduce the risk of developing diabetes by 2/3 by a lifestyle change. And now it's about implementing that change more broadly. And so there is funding for programs that deliver the diabetes prevention program. The American Diabetes Association has one of the grants from the Center for Disease Control to do this. What we need to do now is scale that dramatically, because although it is reimbursed and it is available, only a minority of the people that could benefit from that kind of prevention methodology have really had access to it. So the good news is we know a lot of what works, and now we have to scale it.
Robert, I want to ask you a question likely to get me in trouble with some folks, maybe, I don't know. But I'm doing my research for today's program. I learned about the term clinical inertia. This is my new go-to term, because across a lot of health, I actually haven't seen this term in practice. I'm a layperson in this, but when we talk to people about, cancer, we talk about lots of other both health maladies and chronic conditions, and you sort of look at the unevenness in America in terms of providing health care to that patient. I just know from my own family's experience that if you're in Bartlesville, Oklahoma, you may get a different message than Dallas, Texas, get a different message than in, near Johns Hopkins University or somewhere, that there's a wobbliness of information and practice out there. So clinical inertia is my new favorite term. So the question is, how do you get beyond? So my understanding, clinical inertia is one of the areas that the diabetes community, particularly those trying to advance it, are very worried about. What kinds of incentives can we put in place so that those health providers are out there, not just I may be saying this wrong, resting on their laurels and doing tomorrow just pretty much what they did yesterday, and begin enveloping that patient with new methodologies, new practices, and opportunities. Is that a fair way to frame it?
So there clearly is a need to incorporate new treatments and have more people have access to it. So as an example, there are 2 classes of drugs that have been demonstrated over the last few years to significantly reduce mortality, death, and cardiovascular disease, which is leading cause of death for people with diabetes. Those are SGLT2 medications and GLP-1. And I didn't invent the names. They're not intuitive, but they're a class of drugs, 2 classes of drugs that are available. So what percent of people that would benefit from those drugs based on current guidelines receive them? Only about 15%. 20 at best. And so we know that we could do better. It's a complex system. Access involves payment. affordability, and something that we're certainly working on. But it's also knowledge. And I think on the clinician side, I think there's a knowledge gap, but it's not just knowledge. What we need to do is redesign the healthcare system so that doing the right thing is the easy thing to do, and remove those barriers to move forward. We also need people with diabetes, particularly type 2 diabetes, to understand that the nature of the disease is that it tends to be progressive, and that what works at one point is not always going to work in many cases, and one needs to add additional therapies to stay at the safe goals for blood glucose levels. And so there are a number of issues related to this. We at the American Diabetes Association have an initiative called Overcoming Therapeutic Inertia, this idea that therapy needs to be advanced. Someone comes in, their blood glucose levels are too high, and there's no change in therapy. That shouldn't happen. One needs to be able to make the adjustments to optimize people's health.
Just real finally, unfair question. You've been at the ADA for a while, and you're sort of the Wizard of Oz there. I think you know all this stuff going on. But I guess my question to you is, in terms of the ecosystem out there, and not just the part of it that you're in, do you feel like there are elements of it that are falling backward? Do you feel like we're stuck in a rut, or are you optimistic that things are beginning to tilt forward, that a lot of the challenges we're talking about are getting squarely addressed?
The pandemic has been devastating for the diabetes community. As much as 40% of the people that died from COVID had diabetes.
Wow.
So that has put a big challenge ahead of us. We are slowly coming out of this, and one of the key messages for us at the American Diabetes Association is to ensure that people get back to get to the care that they need, because many people deferred their care. I am encouraged about the future. I think there's a lot of alignment now. The adoption of telemedicine and digital health that we were, in a sense, forced to because of the pandemic, have been new tools to be able to help people with diabetes live healthier. We're having some success in terms of increasing access, shining a bright light on the health disparities that exist, and slowly untangling those. So I think in the coming years, we hope to see a lot of improvement. The tools are better than ever, and now we need to push for greater adoption.
Well, thank you. Dr. Robert Gabbay, Chief Scientific and Medical Officer of the American Diabetes Association. Thanks so much for joining us today and sharing your thoughts, and good luck on all this work. And please come back and give us some updates now and then.
Great. Thank you so much for having me.